that, we'll come back again. So I'll just, you have introduced yourself, but I'll just add on some more things so that everybody knows. Yeah. So we're going to talk about hearing aid, cochlear implant, or bone anchored hearing aid. What are the criteria for choosing and what is right for the patients? So as a speaker, we have Elaine Orcutt, who is AUD, and she's certified, she has certificate of clinical competence in audiology from ASA, and she is lead adult audiologist at Wake Forest Baptist Health Center at North Carolina, USA. If you'd like to share your screen, and we can start ahead.
Okay. All right. And if you have any questions, please let me know. And I think we'll have some time set aside at the end also to kind of talk about this. Any questions afterwards? This is just a picture of our main hospital that our hospital likes for us to show when we do presentations. So just to kind of a brief overview of what I thought would be good to talk about, we'll kind of review hearing aid, cochlear implant technology, and bone conduction hearing device technology, the criteria and candidacy for the devices, and then I've chosen some cases to kind of show some good options for maybe when you should use each one. I will note that some of the candidacy and the options available are different in the United States than in other countries, so I'm kind of talking about what's available in the United States. So there are a lot of different options for amplification for people with hearing loss. Hearing aids are the most common. Cochlear implants are less common. And then there are bone anchored devices, or we also often now refer to them as osseointegrated devices. There are some middle ear implants and surgical intervention, and as well as personal assistive devices. That's becoming more popular in the United States to have things that are over the counter that you can purchase online and things like that. Statistically speaking, in the United States, there's about 36 million Americans, so worldwide, much more obviously, that has some type of hearing loss. There's a higher number, over a third of people age 65 and over have hearing loss, so that's our largest population of people with hearing loss. But there are, you know, an average 1 to 3 children who are born out of 1,000 have hearing loss. And many people wait 10 years or more to actually pursue any kind of amplification options. When we assess people for hearing loss, we use different types of assessment. I work a lot with adults, but I also see a lot of children for cochlear implants, as well as just assessment. For younger children at about age 7 months, we start using what we call VRA, which most of you are probably familiar with, which is where they just turn to the sound, and we reinforce that by lighting up a toy or using a computer screen. And that we use from about age 7 months up to about 2 to 3 years of age. We will use that with some older children as well, but oops, sorry, went too fast. Or people that we can't get to do condition play. So children with autism, children with developmental delays, and even some adults, we use that as well. Condition play audiometries for older children, they can start doing it about age 2.5 to 3 years old. And that's just a task where they wait till they hear the sound and then throw a block in the bucket or something like that. It's a type game type thing, and it tends to keep younger kids more entertained. And we do that with older kids with developmental delays as well. And then we have standard audiometry, which is raising your hand or pushing a button, that type thing. And we also use ABR, or auditory brainstem testing, as well for newborns or for people that are not behaviorally testable. So we try to at least try behavioral testing as well. The different hearing aid styles, on the top you have what we would call custom hearing aids. The size and the shape depends on the size of the person's ear canal, as well as the degree or amount of hearing loss they have. On the bottom, they have what we would call the behind the ear kind, and that's by far the most popular. Most people really like this the E style, and that's what we call the receiver and canal. They like it because it's discreet, and it's very comfortable because it has a soft tip that goes in your ear, and it can keep your ear canal more open. So that's by far, I would say, about 90% of the hearing aids that we fit are that style. We determine that they're a candidate for hearing aids by the type and degree of hearing loss. Like I talked about before, we use behavioral information, but you can also fit based on ABR thresholds. The gold standard is behavioral testing, but sometimes you can't get that. I mean, we also, when we're fitting, we have to consider, you know, the anatomy that they have, if they have any middle ear or ear infection issues, if they have hearing loss in one ear or both ears, and as well as auditory neuropathy. That also goes into consideration when we fit with hearing aids. For children, we typically fit the behind the ear kind just because their ear canals grow pretty quickly. And also just because of retention, it's easier for the kind in your ear to fall out if your ear canal is growing. This kind on your left is the BTE, or the behind the ear with a traditional ear mold. That's the style that we use for children newborn up to, you know, early teenage, like 11 or 12 years old, and sometimes past that. And that's just because it offers the best option to keep it in their ears and stay on, and you can switch out the ear mold style. They are moving towards a lot of the manufacturers, at least in the United States. For children, we primarily use Phonak as our manufacturer. They are starting to have rechargeable options here, so that's been nice. So we don't have to worry about the child swallowing the batteries or anything like that. So that's been a nice addition. As the kids get older, like I said, I typically wait till they're about 10 or 11 years old, sometimes older. We will switch them to a model more like this that's more discreet. A lot of times we have kids who, you know, at 11 or 12 years old don't like to wear this kind because it's more visible. So if they have hearing loss that we can fit with this kind, sometimes we will switch them over just so that they'll continue to wear their devices. But it varies child to child. So with kids and adults, but kids in particular, the goal of hearing aids that we have is to make sure the speech is audible and to minimize the impact of hearing loss and speech and language development. And we also want to make sure that the hearing aids aren't over amplifying the sound. The way that we do that, we verify the hearing aids, and in our clinic we verify the hearing aids for every person, adults and children. And the way we do that, we use what's called a probe mic real ear test, where we put a microphone in the ear canal of the person along with the hearing aid to make sure that the hearing aid isn't over amplifying the sound, but they're getting enough volume to hear all the speech sounds. So this at the bottom is one of the devices that we use. It's called a VeriFit. There's different manufacturers and models, but it is a way that we can, the top, it puts out some sound and it plays phonetically balanced speech passage, and they have different speech passages based on your primary language, tonal versus non-tonal languages, things like that. So it tells you how well the hearing aids are fit, and also make sure you're not over amplifying the sound. Say that again? For younger children, we do, typically they won't sit there for that, so we do some testing in what's called the test box, which is on the lower left, and that's a way that we can kind of just to make sure the hearing aids are fit appropriately for them. This is kind of what the screen looks like, where you have the patient's thresholds, and then the black dots on the top are the maximum output, so you don't want the hearing aids to be above that, or it could cause damage to their hearing. So we try to fit them where they are meeting thresholds, but it's not too loud. And there's a lot of research that shows this is the best method, if possible, to fit hearing aids, particularly for children, when they can't give you feedback on how the hearing aids sound. So Hearing aid retention is important, particularly for kids. I'm sure all of you who fit kids know that and have had to deal with this, with the kids taking them off or losing the hearing aids or things like that. We have things that can clip on. For a lot of our kids, particularly kids who wear cochlear implants, we use the pilot cap, and that helps keep the device on and things like that, because it's expensive when they're lost, and typically the kid goes for a while without having sound if they lose the device. So the limitations of hearing aids, as you probably know, if a person has a lot of hearing loss, or even if they have some hearing loss but their ability to understand speech is poor, the hearing aids don't improve the speech clarity, they make the sound louder. So if, you know, even when the sound is loud enough, they still can't understand speech, the hearing aids are not necessarily going to improve that. And hearing aids themselves also have trouble if the person is far away or there's a lot of background noise. They're limited as to what they can do with their abilities, and that's where we look at other options like a cochlear implant or assistive technology, like an FM system or a microphone that could be beneficial. So we'll move on a little bit to just review bone conduction hearing devices. Probably hearing aids are the most familiar for people, and bone conduction and cochlear implants are a little bit less familiar, so we'll spend more time on those. With bone conduction devices, there are a lot of options out there, and they vary greatly country to country what's available. Oftentimes, there are a lot more things available in Europe than there are in the United States, just because it takes longer for stuff to get approved in the United States. So there is some technology that they might have there that we don't have yet, so things like that. So this is kind of what's available in the United States and what's used often. Sometimes it depends on what your insurance will pay for in the United States, so that does play a big part in sometimes what we pick for people. So these are just a few kind of options. Some of these, obviously, this is from Med-El, that's one of the manufacturers, and there are some different companies that make devices. So a bone conduction hearing device is typically positioned either surgically or non-surgically on the mastoid, the bone behind the ear, and it uses a multi-channel bone oscillator that stimulates the inner ear via bone conduction. And the device is programmed specifically for the patient's bone conduction thresholds. There are some devices that aren't programmed specifically. Those, at least in the States, are being used less often, and most of them now are digital, so you can program them a little bit better. To use a bone conduction hearing device, the Candidacy, typically they are indicated for people who have single-sided deafness. So they have no hearing in one ear and normal hearing in the other ear, or conductive and mixed hearing loss, either in one ear or both ears. So Cochlear Americas is one of the companies that manufactures a lot of bone conduction devices for the United States. And their Candidacy guidelines for single-sided deafness indicate that you have in your normal hearing ear that you pretty much have normal hearing, and then in the worst ear you don't have any hearing or profound hearing loss. So this would be an example of somebody who would be a candidate for single-sided deafness bone conduction. As you see, the left ear, the X's, they're normal hearing in that ear, and then in the right ear at the bottom, the red, they have profound hearing loss. So this is kind of a simulation of how it will work. The person would have the bone conducted hearing device on their right ear, and the sound would be sent via vibration through the skull over to the left cochlea or inner ear. So this is going to give the person access to sound from the right side in their left ear. It is still just using one ear, it's not using both ears, but it does give the person access to sound on that side. So there are a few other options for somebody who has hearing loss in one ear and normal hearing in the other ear. The bone conduction device is one. Another device that is not a surgical device is called a cross hearing aid. And that is essentially you wear a hearing aid in your better hearing ear, and then you wear a transmitter in your bad ear, and the transmitter picks up the sound from the bad side and it sends it over to the good side. It's the same method as the bone conduction, it just uses a different transmission. A cochlear implant is another option, and until last year, it was not approved by our governing government for use, so people had to get special permission to use it for this. But a cochlear implant is also an option, and it allows people to hear from both sides. So we're starting to do more of those in the past year. Times that you wouldn't be a good candidate for a cochlear implant in this situation would be if you had some type of tumor on your nerve, auditory neuropathy, or any kind of abnormality of the cochlea. So we'll go a little bit more in depth in this a little bit later. So one of the big indications for bone conduction hearing devices is conductive and mixed ear hearing loss. So we see a lot of kids with microtia or atresia, which, as you probably know, just means they don't have their pinna, or their ear canal is completely closed off, so they're having trouble getting the sound transmitted to the inner ear. We see a lot of kids that have, middle ear infections, or drainage in their ears, or they might have some kind of problem with the bones in their middle ear that causes a problem transmitting the sound. And they might also have ear canal stenosis. We see that with some adults where their ear canals get smaller. Over time, they just kind of close up, so you can't put a traditional hearing aid in the ear canal. With mixed hearing loss, that simply, I'm sure most of you know this, but that just means that you have conductive hearing loss along with sensorineural hearing loss. And that can happen. We have some people who have that just as they get older. They might have something wrong with their middle ear bones, but they're also losing their hearing just from aging. Or it could be that they had a surgery at some point that caused some hearing loss as well. And that can cause that. And there are several syndromes that are associated with mixed or conductive hearing loss. Osteogenesis imperfecta, a lot of people with Down syndrome have this type of hearing loss, so there's a lot of different syndromes that are associated with this type of hearing loss. One of the main ones that we use in our clinic is the Cochlear BAHA 5 system. That's the newest system available for us, and this is from their information. There are different power levels that are used based on the bone conduction of the ear that you're trying to transmit to. So you can have a smaller one if you have pretty good bone conduction. If you come in more into, mixed hearing loss or something, you need a more powerful one, and that's what this super power one looks like. So prior to doing the surgery or getting the device, we do testing ahead of time to see where their thresholds are, and we try to pick a device that's appropriate for them. Just like with hearing aids, you want to err on the side of if their hearing changes, they need to be able to have room if their hearing gets worse. So we try to make sure we pick one that if something changes, they'll still be fit appropriately. These are, in our clinic, what we use the most. We have 2 ear surgeons, and they see a lot of people with mixed or conductive hearing loss. So we do these surgeries pretty frequently at our hospital and use these devices a lot. So this is an example of a conductive hearing loss. And in this case, you could use the smaller one. So you can see on the left in the audiogram, the left ear has normal hearing. The right ear has what we would call moderately severe to severe conductive hearing loss. So the bone in the right ear is good. It's just transmitting the sound from whatever's causing that. So this person would be a great candidate for a BAHA or a bone conductive device. This is kind of an ideal candidate, actually. This would be an example. This one would be a more challenging one just because they have hearing loss in both ears. If you look on the left, in the left ear they have a moderate hearing loss. We don't have the bone for that, but we'll assume that it's sensory neural. And the right ear, they have a profound, what we would call mixed hearing loss. Now in this case, you know, somebody might try a hearing aid on that, but this would be the right ear would be hard to fit a hearing aid on just because of how much hearing loss it is. And, you know, with that much hearing loss, you run the risk of having feedback and, you know, problems with the fit or not being able to get enough volume. And that's where you would consider the bone conduction device. Just because of how much hearing loss they have, this person needed the superpower, which is the one on the right that provides the most amplification. So we'll move on to cochlear implants now. I want to be conscientious of our time so we can do some cases at the end also. So cochlear implants are my specialty. They're what I spend most of my time doing. So they're kind of my passion in a population that I enjoy working with. This is what kind of the basic system of a cochlear implant. This is made by a company, Cochlear Americas. There are more than one manufacturer. This is just an example of one. This part on your left is the outside processor. That's what's worn on the ear, and you have to have this part. And then you have the internal part that the surgeon places, the electrode array. So a cochlear implant is very different than any of the other devices. It is a surgically implanted device that uses electrical stimulation instead of acoustic or vibration. So it sounds quite different to people compared to a hearing aid or a bone conduction device. And cochlear implants are indicated when there's, you know, so much hearing loss or so much damage that even with a hearing aid, the sound is still not clear. And typically that happens because there's damage to the inner ear hair cells. So the cochlear implant kind of bypasses the damaged hair cells in the cochlea, and it stimulates the nerve fibers directly through electrical current. So it's a very different type of sound than, as I said, so it does take some time for the person to get used to it. It's not something that you turn it on and it sounds normal. It takes time. So in the United, this is another time where I'll say the United States has different criteria than other countries, so it's important to know the criteria of where you are. But this is our criteria in the United States. For an traditional cochlear implant, a person needs to have moderate to severe sensory neural hearing loss in both ears. And the most important thing, they have to have testing to determine how well they understand sentences and words without visual input. So the testing is performed using recorded speech, so it's just an auditory test. They have to score 50% or less in sentence recognition in the ear to be implanted and 60% or less in the other ear. There are some indications now for a hybrid implant, which is part hearing aid and part cochlear implant. So that's another option. And again, this is just a different kind of model of it. This is a good example down here of what it looks like, where there's an ear mold that would provide the acoustic part. And then you have the device behind your ear as well. And a similar candidacy for that. Like I said earlier, the FDA, which is the Federal Drug Administration in the United States, approved last year that we could use implants for single-sided deafness or asymmetric hearing loss, which that was a huge improvement. And we were excited to have that changed. The criteria for that, the person needs to have profound hearing loss in the ear to be implanted and normal to mild hearing loss in the other ear. Right now it's approved for kids 5 years and older. I think they'll change that in the future as there's more research done. And they have to have quite a bit of hearing loss and perform pretty poorly in the ear to be implanted. This is a very similar thing. They can have more hearing loss. They just have to perform pretty poorly in the ear to be implanted. The one note for the approval They recommend that the person's hearing loss be 10 years or less. If they've had hearing loss in that ear for over 10 years, it's a contraindication, just because of going that long without any kind of stimulation. The performance tends to not be as well with cochlear implants. When we test people for implants, like I said, we test their thresholds, but we also do a lot of sentence and word testing to see how well they perform. There's something called the minimum speech test battery that we use, and all this is recorded testing or recorded speech. This is an example of some of the sentences we use. We have several lists so that the patient can't be familiar with them, and we just ask them to repeat back as much of the sentence as they can. It's kind of they don't really make sense. They're kind of meant to be sentences that you couldn't guess, that you're just not sure of, just to kind of test how well they can perform with hearing aids. And all this is done with hearing aids. The things that we consider when we're considering an implant is how long they've had hearing loss, and how long they've worn hearing aids. That they tend to be a better candidate the shorter the duration of their hearing loss, and if they've worn hearing aids, and that's just because their auditory nerve has been stimulated. If they go for years and years and years without hearing anything, and then you put an implant on, typically they will have sound awareness, but they will have a harder time understanding speech in that situation. The cognitive status is also important, and then how the family support and their ability to be around people talking and to get speech therapy and things like that to kind of help rehabilitate them to listening again, and listening with this new device is very important. These are just some of the electrode arrays that are available, and they use different ones for different cochleas and different types of surgeries and things like that. They're also, the length of the cochlea varies person to person, so before they do an implant, they always do imaging to look at the cochlea so they can make sure they get the appropriate type of implant for that person, because everybody's a little bit different. And then these are just sound processor examples. There are, like I said, different companies and different countries have different options for sound processors. We've had several people come to our clinic from different countries, and they'll have equipment that we don't have available in the United States and vice versa. So it varies country to country. This is what we have in the States. There are some behind the ear options, and then there are also some that just connect directly and you don't have anything behind your ear. Typically for kids and people that are more active, we get this kind because it doesn't fall off as easy. But some people like how discreet or less visible this kind is, that just sits right where the magnet is. When we see the person, we see them about 3 weeks after surgery to turn their device on, and then we have them come back about 5 to 7 times in the first year for programming and testing and things like that. And then we still see them about once a year just to make sure everything's functioning appropriately. Their initial reactions when we turn on their cochlear implant vary. A lot of children will cry because they don't understand what's going on or what's happening. Sometimes they won't do anything. Adults can tell us it sounds like a very weird voice or beeps and buzzing, and it's a gradual adaptation process, so it can take months for them to understand voices. And sometimes it can be overwhelming because they haven't heard this way before, because it's an electrical signal, so it does take time for them to adapt to it. It's not a quick thing, and they need to be, we remind them of that a lot before we do the surgery so that they're aware of that, and that it takes time and effort for it to be successful. So there are a lot of different ways to program, and it's pretty different than programming with hearing aids or bone conduction, because a lot of it you're looking at, we can't listen to the implant like we can a hearing aid. We just have to rely on what the patient tells us. But there are some objective measures that we use also, like the compound action potential is essentially an electrical ABR. So there are some ways that we can do testing if the patient isn't behaviorally testable as well. It is important, and since my sister's a speech pathologist, I'll put this importance in. It's important for therapy after getting a cochlear implant because they need to learn how to listen with the cochlear implant, and therapy is important. It kind of helps assist them in gaining understanding or meaning to the sound, and it's important for them to learn how to listen with the cochlear implant. With all three, the hearing aid, the cochlear implant, and the BAHA or the bone conduction, there is assistive technology. These options right here are microphones that are, and this is to your right, a TV device that you can connect. And what this does is it just, these microphones you can have other people wear, and it sends the sound from that person directly to the device. So it just helps you understand if you're far away or if there's a lot of background noise. So they're very, very helpful, and we use those quite a bit. And then now, a lot of our hearing aids and cochlear implants are able to be connected to smartphones so that the patient can make adjustments themselves, which has been very nice. It gives them more control, and it causes them to not have to come in quite as often because they can make adjustments themselves to devices. And actually, during all this coronavirus stuff, some of them now we can connect remotely and program from a distance this way. So that's been very helpful because we can do programming adjustments without them having to come into the clinic, which has been helpful. They do require, they have to, you know, have a smartphone and internet and things like that. So that's some of a challenge. But if they have that, it can work pretty well. So I think it says we have about a minute left, so I don't know if we want to do the cases maybe in the next time.
Yeah, what we'll do is we'll break it now, and we'll click the same link again and join for another session. So we'll do the cases and then do the question and answer and discussion after that. Is that okay?
Okay, sounds good.
I request all of you to click the same link again and join us in a minute. Thank you all. Yeah, I welcome back everyone. So yeah, we'll just wait for some more time, a minute or two, so that everybody can join, and then we'll continue with your presentation.
Okay.
Yeah, you can share your screen in the meantime.
All right. Well, I think it says it's disabled for me to share the screen.
Just 1 second.
Okay.
Yeah, can you try now?
Okay.
Yeah, I think we can continue now.
So these are just a few cases that I've put together of there are patients that I've seen in the past year or so, and the three of them, there were different options, and they actually tried multiple options. Some of them ended up with the bone conduction and some with a cochlear implant. So it's just kind of good to kind of look at them and see what would be the best option. This first one, whoops, I went too fast. This first one is an adult that we saw in clinic last year. He had a sudden hearing loss in his left ear. He woke up just no hearing in his left ear, and he had never had any trouble before that. And this was his hearing test the first time I saw him. And you can see in his right ear he had pretty normal hearing. And then in his left ear he had profound sensory neural hearing loss. Of note, sometimes what I do if the person says that they feel it instead of hearing the sound, I just write that as vibrotactile. That's what the VT notification is under that. His word understanding was really good in his right ear, and he couldn't understand words at all in his left ear. So he saw our ear, nose, and throat physician, and they tried steroids and they tried intratympanic steroid injections, and his hearing did not improve, which sometimes people have that, but he had no success with his hearing improving. So with him, I offered him 3 different options. Actually 4. I told him he didn't have to do anything, but he had very bothersome tinnitus in his left ear. He reported he was having a lot of trouble in background noise. His job was at the hospital in a very noisy place, so he was having trouble communicating with people just because of the noise. And he was having a lot of trouble and concern about his safety because he couldn't tell where sound was coming from after this. So I saw him back and we tried, we let him try a cross hearing aid because that is a pretty easy thing. It's not a surgical thing, so they can put it on and try it. And he came back and he reported he liked being able to hear sound from his left side, but he had trouble figuring out where sound was coming from, and he still had a lot of trouble in background noise. So another option for this with the single-sided is the bone conduction, but the limitations with the cross and the bone conduction in this kind of scenario is that you're still just using one cochlea or one inner ear. You're not using sound from both sides, so you'll still have trouble filtering out background noise and telling where sound is coming from. So he was actually our first person that we did a cochlear implant for single-sided deafness. So he got his implant now, it's been about 8 months ago. And he immediately, when we turned it on, and part of that is because he had hearing in that ear fairly recently. He started hearing pretty well with his cochlear implant, and he's had it now, like I said, 8 or 9 months. And finds that it's very helpful because he can hear sound now on both sides, and he doesn't feel like it's as hard to hear in background noise as it was with just hearing from the right ear. So he reports he's less tired and can perform his job better having access to sound now on both sides. So that was a good positive option with the cochlear implant, which isn't something even 3 or 4 years ago that would have been an option for him. These 2 audiograms are from the same patient. It's a child that I've been following now for about 7 or 8 years, and she has Down syndrome. So she's had several sets of tubes in her ears and has had ear infections and things like that. The audiogram on her left is an older one, and she's had hearing aids for several years, and she did really well with hearing aids, but then she started getting a lot of ear infections again in her left ear, and she had a few surgeries on her left ear, but she continued to have drainage out of her left ear, so it made it hard for her to be able to wear the hearing aid in that ear because it just kept getting stopped up with drainage. So this is on the right a more recent audiogram, and you can see where the left ear has kind of gotten worse. Excuse me, particularly the air conduction because of the fluid and things like that. So we actually let her try a bone conduction hearing aid on that side, a BAHA. We put it on a soft band for her to try, and she loves it and feels like she hears a lot better. So she's in the process of, she will have a surgery for the BAHA device. It kind of got postponed with the coronavirus, but that will be coming up. And we still have plans. She'll still wear a hearing aid in her right ear, and then on the left side we'll use the bone conduction device. And then this last one this is all the same patient. This is another teenager, so I think she is 16, maybe 16 or 17 years old. And she's had hearing loss. She was not born with hearing loss, but she acquired it a progressive hearing loss over time, and she wore hearing aids for about 4 or 5 years, and then we kind of lost her. They moved away and then they came back. And so I started seeing her again last year, and this is her hearing loss. So she has very good hearing in the low pitches and then a lot of hearing loss in the high pitches. And you can see from her word understanding, even when it was loud enough that she could tolerate it, she only understood 4% of the words in the right ear and 40% in the left ear. Excuse me. So we did testing for her for a cochlear implant. And when we do the testing, like I said, we did testing, the A stands for aided. So we did testing with hearing aids. And we showed, you know, she hears pretty well at the low and mid pitches, but even with hearing aids, she's not hearing very well in the high pitches. Yes, I'll explain the candidacy for bimodal fitting. That's a good question. I'll do that when I finish with this. Sorry, I have a tickle in my throat. So this other testing down here is how well she performs with sentences. And you can see she was only getting 24 to 38% with both of those. Excuse me, just one moment.
Yeah, in the meantime, if anyone has questions, please type on the chat section, so we'll have a discussion after this case. Yeah, anything related to today or anything extra, what you would have thought in certain cases or certain conditions?
All right, I had to get some more water.
Yeah, no worries.
All right, let me go back. So she got an implant in her right ear, and this bottom audiogram shows she actually got an implant that was one of the hybrid ones, so they tried to preserve the hearing that she does have. And this is actually the hearing that she still has in that ear. So you can see her hearing didn't really change very much from before the surgery and after the surgery. The biggest difference is how well she understands speech now with the implant. She went from 24 to 90%. So a huge improvement with the implant. With the bimodal fitting, that's a good question. So bimodal, just having, really you could have a hearing aid and implant or a hearing aid and a bone conduction device. For most of our cochlear implant patients, if they qualify for a cochlear implant, we fit them. If they have any kind of hearing at all in their other ear, we let them try a hearing aid in that ear. We do have some patients that get 2 cochlear implants. In the United States, with some of our insurances, it's harder to get that approved. A lot of our older patients, it's harder to get their insurance to approve implanting in both ears. So we will have them, if they have any hearing loss, and it's, you know, hearing loss that, you know, they don't have profound hearing loss, we will put a hearing aid in their other ear. And you know, there's a lot of research and studies that show that people perform best if they have a device in 2 ears versus just 1, particularly in background noise. So, all right, I think that's all I have. If anybody has any questions, feel free. So yeah, one question, that's a good question. Cochlear implant with auditory neuropathy. That varies. We typically, our protocol for implanting kids with auditory neuropathy, we wait until we can get some behavioral information on them. So typically they get implanted a little bit later than, you know, if the kid has, you know, profound hearing loss. we try to implant them now. The criteria has changed so they can get implanted as early as 9 months. It was 12 months of age up until a few months ago. They actually changed the criteria. But with neuropathy, I would say probably the earliest that we've implanted kids has been about 17 or 18 months. And we have implanted some that are older than that, because, you know, with neuropathy, their thresholds can fluctuate and things like that. And it's really been kind of a variety of how well kids do with it. I have a few kids with neuropathy that perform really well with their implant, but they go to speech therapy every week and do a lot of therapy, which I think makes a big difference. And then I have a few kids with auditory neuropathy that they only get sound awareness with their implant. So it just kind of varies. I think that that's an area that they're still doing a lot of research in. But I would say, you know, if it gives them better access to sound with an implant, then that's a good opportunity. So we always kind of talk to patients about those options. I have not done really much work with brainstem implants in the United States. That's one of the questions. In the United States, there's maybe 5 or 6 sites that do brainstem implants. The closest one for us is in New York at NYU. So I haven't had much experience with that. I have sent, I had a child that had, with their MRI, they didn't have an auditory nerve. So we still implanted them to see, because, you know, in the MRI sometimes you might not see everything. So they still recommended we implanted him with a cochlear implant, and he got some benefit from it, but not as much as they wanted, and they did a brainstem implant for him. That is, so the question, can ANSD be max benefited from an ABI? I haven't seen a lot of research on that. I don't know that I would go that route. I would certainly, I think when I've talked with the people at NYU about it, they've recommended, you know, you try the cochlear implant first and see what benefit is from that. Because the ABI is a, you know, much more invasive surgery, and it's a much harder thing to get. And a lot of times with the ABI, you get sound awareness, not necessarily speech understanding. So the cochlear implant for adult auditory neuropathy patients, that is a good question. We, you know, a lot of times auditory neuropathy is still something that is relatively new. So there likely are adults out there that have auditory neuropathy. Yes, NYU, sorry, is New York University. Yes, thanks, Sarah. Auditory neuropathy with adults, a lot of times we don't necessarily know that they have auditory neuropathy because they're not always undergoing ABRs. So I would say if they get to that point, they would probably do well if they've had, it's the same kind of thing if they've had hearing aids and they've worn hearing aids. The problem with adults and older children, if they have been profoundly deaf and they have not had any kind of stimulation from, you know, a hearing aid or something, then they typically don't do as well with a cochlear implant, just because their auditory nerve and their brain are not used to sound. So they might get sound awareness, but not necessarily speech understanding. Let me look and see.
There are a few questions which have been sent to me. Yeah, I can read that to you. Is that okay?
Okay.
Yeah. So, yeah, the one which is right there is, would you please state your experience with reverse sloping? I think it's almost the same as how you're getting auditory neuropathy as well.
Yeah. Are you, for reverse sloping, are you talking about for hearing aids or cochlear implants?
I think in general.
General.
Yeah, your experience with them.
So it has been, for reverse sloping, it is it's harder to fit the hearing aids, I would say, because, you know, most a lot of background noise is low frequency. So a lot of people, if they have normal hearing in the high pitches and then hearing loss in the low pitches, they have a lot of trouble still picking up sound because they're picking up more background noise as well. So I think it's important to use technology that has noise reduction and things like that. That seems to help. We do have some cochlear implant patients that have the reverse slipping, and that doesn't really seem to be a problem, just because in that scenario they're going to get an all electrical sound. So it kind of takes away the problem of the reverse slipping, but it is a lot harder to fit a low frequency. But I think the technology with the noise reduction and things like that has helped tremendously. In the 10 years that I've been doing it, I've had a lot more success with people if we can get the kind of hearing aids that have noise reduction and things like that for the reverse slipping.
Yeah. I mean, I've not done it particularly, but I've read it somewhere. I mean, to the reverse sloping part, instead of fitting to the exact thresholds, they generally take an average of it and make a flat audiogram, which seems to help with the low frequency, which is like the noise component to be much less, and then the speech will be much more better. I've always thought like I'll try it in some of the cases, but somehow I missed that. So maybe I'll remember next time when I see a reverse sloping.
Yeah, I do tend to not give them as much volume at like 250 hertz.
Yeah.
Because there's not as much speech information there. So I do tend to do that, and then I still, even if they have, good hearing in the high pitches, I still tend to give them some amplification there because it seems to make it sound more natural to them than just fitting solely based on the audiogram.
Yeah. So the next question is, what specific hearing aid fitting consideration we can use with ANSD patient, if you have anything?
So for ANSD, we try to fit them. If we can't get behavioral, at our clinic, we don't fit them really until we can get some behavioral information. Sometimes we're finding more and more of these kids who have been in the hospital when they're born, the NICU, the neonatal intensive care, that they will have auditory neuropathy, but they'll also have some waveforms, wave 3 and 5. So sometimes we can fit conservatively based off of that. But we tend to test them more often than kids who just have hearing loss because their thresholds can fluctuate. And we tend to kind of fit them a little bit more conservatively so we don't give them as much volume maybe as we would another child, just until we kind of get a clearer picture of what their hearing really is as the older they get. Because it can, it tends to fluctuate more than a lot of hearing losses do. So we tend to bring them back fairly often to test.
I think the outcome variability with auditory neuropathy is because the condition itself is very variable from from mild hearing loss to profound hearing loss with having different configurations of hearing loss. So that is one thing which makes it more trickier than anything else.
And a lot of kids who have auditory neuropathy also have other developmental delays or comorbidities, so they can be more challenging to test in general. So it's a really tough population to work with, and I think how we program and test changes a lot just as we learn more information. But we have a lot of kids that were born at 23 or 24 weeks, and they're at higher risk for auditory neuropathy. So there is a lot of we bring them back pretty frequently to try to get a better picture, because sometimes we'll only get one threshold that day or something like that.
So there's one more question which says based upon different types of hearing aid which we discussed, like from BTE to custom hearing aids to rigs, which model do you think most people tend to prefer in the USA?
I would say a very large, I don't know the exact percentage, but I would say by far most people fit the receiver and canal behind the ear type. And that's just, for us, we don't have to wait as long to order the hearing aid because it's not a custom one. If the person's hearing changes, we can switch out the receiver and put a more powerful one on. For most people, having that dome is a lot more comfortable in their ear. In the United States, most of the time, the newest technology is in that model, and it takes another year or two before the custom has, the new technology. So we tend to fit that the RIC, or the receiver and canal type, the most.
Okay. So there's another question which says, like, how would you deal with a patient who has only loss at 8,000 hertz but has a tinnitus?
So we do, I'm not an expert in tinnitus, so we have a clinician who works with me who does, but a lot of times we have people who still try hearing aids, even if they only have hearing loss at 8,000 hertz, if their tinnitus is bad enough. A lot of our hearing aids now have a tinnitus masker or generator built in. If hearing aids, those are expensive, so we have a lot of people that use, a lot of the smartphones now have a tinnitus app on them that have a sound generator or things like that that can be helpful. It's less expensive than hearing aids, but we do have some that if their tinnitus is really bothersome, they try hearing aids even if they only have hearing loss at 8,000 hertz or something like that.
So I think this is more related to the cochlear implant, and I think you'll be the perfect person to answer this. How often do you do ASSR, steady state response?
We really don't do that very often. We tend to, at our clinic and some of the other clinics in our area, we do the click ABR, and then we do tone burst ABR, and then we have a protocol now where we do tone burst bone conduction as well, so that gives us a pretty clear picture of what they're dealing with.
Okay. So is there any consideration that you will take into account if you are fitting individual with noise-induced hearing loss?
Not necessarily. We because that's a lot of what we see. We have a lot of people here who do construction work, or who have been in the military and things. So a lot of times that is what their hearing loss is like. When we fit people with hearing aids, we do additional testing to look at their loudness discomfort level. So that is important when you're fitting the hearing aid, to know what their loudness tolerance is. We do that typically at 500, 1,000, 2,000, and 4,000 hertz. And if you're in a rush, you can just test this at 500 and 3,000 hertz, but I like to have a little bit more information. And I simply do it, I go up maybe to like 90 or 95 decibels, and I present, and I just tell the person to tell me when it becomes too loud for them. And that's where we know kind of their loudness discomfort, and that helps us, that recruitment, and that's exactly what that is. I think if you measure their loudness discomfort, that's one of the best ways I've found to kind of deal with recruitment. Because then, if you just fit them, most hearing aid software doesn't take that into account unless you enter that into the software. If you enter their loudness discomfort, it tends to adjust their MPO, or maximum power output. So for most people, if they have recruitment issues, we tend to lower their levels at the loud gain as well as the MPO, or the maximum power output.
Yeah, I think if I have to share my experience along with yours, and I feel using like uncomfortable level most of the time solves the problem with cochlear pathologies, whether it be NIHL or any other cause. If there's chances of recruitment, using the uncomfortable level definitely pulls down the maximum output, and then the discomfort will be minimal. And again, we have WDRC technology, which generally take care of if we can pull the MPOs down. So I think that's it. I think,
and it does. And I have some people that have really bad loudness recruitment, and I've had a few people that we have to turn. We set their hearing aids to target, but sometimes we have to we call it a sound diet, which is where we start them very soft, and we do where we'll have programs, or some of the software now you can actually set it so it'll gradually increase or acclimate to it. And I've had a few that have been successful where we start them very soft, and gradually over time we turn it up to where they need to be. But that is, sometimes it just takes a lot of counseling too. But definitely inputting their uncomfortable or loudness discomfort levels is important.
Yeah. So there are a few more questions which I'll go on. So the next question is, when you're doing when you're fitting the targets, do you use the proprietary ones or the generic ones, like null annulled 1, 2s, DSL-IO, or go with the company?
Yeah, so typically for children, I use the DSL child. For adults who are new hearing aid users, or even ones who have, are used to digital hearing aids, I typically use the NAL NL2 one. The DSL tends to give you more volume, so if you have somebody who maybe has loudness recruitment, I would probably use NAL because it doesn't seem to give as much volume. But there was a study done, it was done years ago, but it showed that people, once a person gets used to something, their performance tends to be the same as long as they're kept in the same prescription. But we tend to, just because we tend to switch to NAL or DSL and not keep it in whatever the manufacturer has prescribed. We change it typically.
Yeah. In terms of bone conduction hearing aids we talked about, we don't generally go for the surgical options until they are like 15 or 16. So how do you decide upon whether it will be a temporary solution for them or a permanent solution? Is there anything that you do, or do you wait until that age, or how do you?
So we actually, in the United States, you can start doing the surgical, I think it's at age 6 or 7. So it is a little bit younger. The kids are certainly involved in that decision. And if it's, we work very closely with our ear surgeons here, which is very nice, because we have some kids that if they have an atresia or something like that, they might be having surgery, but they tend to still get the surgical device, just because even with atresia surgery and things like that, a lot of times they still might have some conductive hearing loss, or their ear canal could close up again over time. So it's still an option. We started doing more of, it's called the Attract, which is a magnet. So it's more discreet, and Cochlear has come out with, it's called the Ossia device. It came out in the United States maybe in February, and it's under the skin. So I think that will be something that will be kind of exciting and new. We haven't done any because we haven't been doing any surgeries right now with the coronavirus. And a big part with all these bone conduction things is if insurance will pay for it. Med-El, which is another company, also has a lot of good options, but a lot of them, it's hard to get insurance to pay for it here, so we don't use them as frequently.
Okay. Since you have used cochlear implants or bone conduction devices and cross hearing aids in single-sided deafness, so what is your experience with what is the outcome in terms of localization, if you can comment on that?
I think, we don't do specific testing about sound localization, just because our sound booths aren't really big enough to have enough speakers for it to be accurate. That would be like more research facilities can do that type of thing. But the study on the single-sided deafness with the cochlear implant, and that was done at University of North Carolina. They had people who got the cochlear implant for single-sided deafness had significant improvement in their localization of sound. With the technology for the cross and the bone conduction is getting better to help localize sound, but you're still always going to have that trouble with those two, is that you're just using one cochlea. So you still have trouble. It all still sounds like it's coming from that one side. So I think it definitely just subjectively, and then from the research, localization improves with the cochlear implant.
Okay, we've got two more questions just now. So
Okay.
both are in terms of channels. So the first question is, how many channels do you think is minimum required for a good speech perception?
That's a good question. I think it varies based on the hearing test. You know, if somebody has a flat hearing loss, you really don't need that many channels. If somebody has, you know, a sloping hearing loss, it can matter quite a bit more. Normally for me, with our software, you can pick if most of our hearing aids now have about 20 channels. But you can change the screen so that you can adjust. I think it's 6, 8, 10, and then 20 channels. I normally adjust, you know, 8 to 10 channels. And, you know, I think you would be really, really fine tuning to do 20 channels. I don't think that's really necessary. Most people do well with just having 10 channels adjusted. But I could see if you had a hearing loss, like the last one that I showed, where at 500 hertz, her hearing was at 30, and then at 1,000 hertz, it was at 65. In that scenario, it is beneficial to have more channels for that type of adjustment.
Yeah, I think, and if we go by the theory or the research, I think they say 8 channel is the minimum that is good enough. So I think that would be the answer. So what is your take on channel-free hearing aids? Like Burnaphone, they generally call their hearing aids as channel-free. I don't know how much you do Burnaphone in USA.
I have never worked with Burnaphone, so I don't really have much experience with that. They're not as popular over here, so I don't have an answer for that. I haven't worked with that. So I'll have to research that and see about it.
I think the basic question was about what exactly channel-free means, whether they don't have channels or they have like swiftly moving interleaved channel between them. I think that is the right question.
Yeah. I'm not sure. I haven't actually heard of channel-free, so I don't know.
Yeah, Burnaphone, they generally call their hearing aids as channel-free hearing aids. So you don't need to worry about whether you have 8 channels or like 20 channels or 2 channels.
Yeah, I'll have to look into that and learn about that.
Yeah, and on the topic of Burnaphone, I think there's one more questionnaire which generally is there from Burn, which they use to identify how benefit the localization is with the hearing aid. So if you ever want to use that, there's a questionnaire which you can use it. So
yeah,
it's
that's
from
great. Yeah, we work primarily with Phonak and Resound, and then we have recently started doing Oticon some. So
yeah, I think all the questions are done, and I think we had a very good discussion as a whole. And I thank you for a very good presentation. And
well, and if anybody has any questions, my email address is up here. Feel free to email me, and I'll be happy to help. And thank you for listening.
Yeah, and we'll be in touch with you. And thank you very much.
All right, thanks.
Have a good day.
You too. Bye-bye.
Okay, bye-bye. Okay, we're going to close the meeting now. Everybody stay home, stay safe. Have a good day ahead. Thank you. Bye-bye.